Okay, great. Um, we'll let folks come in slowly. I'll give it another minute and then we can start. So welcome everyone. Thank you for attending our Gutsy Learning series today on arthritis and Crohn's and colitis. So my name is Roshane, and I am the Manager of Research Grants, Research Impact Communication, and Evaluation at Crohn's and Colitis Canada. Before we kick things off, let's go over some technical details. This session is offered both in English and French. To access the French audio, click on the interpretation button in the bottom. It's the globe icon in the Zoom menu bar and select the French language. If you encounter any technical issues, try refreshing your website browser or restarting the Zoom webinar. Alternatively, share your concerns in the Q&A box. Share your concerns in the Q&A box below in the Zoom bar, and we'll try our best to assist you as soon as possible. Okay. I would also like to acknowledge the rich history and heritage of Canada's Indigenous people. From coast to coast to coast, we recognize the ancestral and unceded territory of the Inuit, the Métis, and First Nations people who call this land their home. Through this acknowledgement, we express respect for the traditional territories of Indigenous communities and contribute to the promotion of reconciliation. Next, I'd like to issue a disclaimer. The content in this presentation by Crohn's and Colitis Canada is solely for educational purposes. While the information holds general value, it may not be applicable to specific medical conditions. Online resources should not be seen as a substitute for personalized judgment and care provided by a trained healthcare professional. Crohn's and Colitis Canada does not endorse any external product or service mentioned during this webinar. For those of you joining us for the first time, allow me to share Crohn's and Colitis Canada's commitment with you. Our organization is dedicated to discovering a cure for Crohn's and colitis, and through research, education, awareness, and advocacy, our organization strives to enhance the lives of everyone affected by these chronic conditions. We appreciate your interest in our organization and hope to make a positive impact in the lives of our IBD community. We'd also like to take a moment to highlight our upcoming Gutsy Learning series, which is on pediatric to elderly care in IBD by Dr. John Shu. And this will be taking place on November 26th from 7 to 8:30 p.m. You can find more details about the upcoming events listed on the screen here or register for them at crohnsandcolitis.canada. If you just click the QR code, you should be able to gain access to this. If you know someone who is living with Crohn's and colitis, we also invite you to explore our Crohn's and Colitis Connect platform. So this is an online community which offers the opportunity to engage with individuals who understand the challenges of living with inflammatory bowel disease, providing a platform to seek advice and understanding. Okay. Now, let me introduce to you our speaker for today's event. We are thrilled to welcome our speaker, Dr. Janet Pope. First, I'd like to thank Dr. Janet Pope for spending time with us here today. A little bit about her. Dr. Janet Pope is a professor of medicine and a rheumatologist at the University of Western Ontario, the Schulich School of Medicine. She has published over 600 articles, resulting in several research accolades, and is also a passionate teacher and educator, especially in rheumatoid arthritis, lupus, and scleroderma. She teaches her colleagues, trainees, and patients with an engaging style. She currently co-hosts a podcast called Around the Room after being featured as a regular guest. You can also find Janet on Twitter or X, where her #ClinicalPearls have a reputation of teaching research findings to over 19,500 followers. Thank you, Janet, for being here to help us raise awareness on this very important topic. And Janet, please take it away from here.
Great, thank you. And thank you so many people for attending. Bienvenue. I'm thrilled as well that we will have this in both en anglais and en français. So I wanted to talk about arthritis conditions that can occur more frequently if someone is suffering from either Crohn's or ulcerative colitis. Next slide.
Sorry, Janet. Quickly, I forgot that we have a poll. So we're quickly gonna launch the poll.
Okay.
It's for us to assess, before and after the session.
Oh, right, the knowledge. Okay.
Yes.
So I forgot to.
No,
So
apologies. It's my fault.
So we have a poll, and again, you're going to be reading it in English or in French. So how would you rate your current knowledge of arthritis and Crohn's and colitis from 0, not knowledgeable, to 10, extremely? And then you'll click on what you think, and then you can actually send it, like click, it will happen. And we're hoping you'll learn more than what you know right now today.
I'll just give it another minute and then I will end the poll.
Yeah.
Okay, we can continue. Thank you, everyone.
Great. So we'll be talking about managing Crohn's and ulcerative colitis with respect to arthritis. So what do we need to know? We need to identify the types of arthritis linked to Crohn's and ulcerative colitis, understand when people with Crohn's and ulcerative colitis should see a specialist that specializes in arthritis. That's called a rheumatologist, and review some of the treatments for inflammatory bowel disease that may or may not be effective for inflammatory arthritis. Next slide. So what is arthritis? Many people talk about this term, but what we're meaning is inflammation and or damage of a joint or several joints. It could be the spine, it could be your knee, your ankle, other joints, and it would cause joint pain, stiffness, and inflammation. In Crohn's and ulcerative colitis, arthritis is one of the most common manifestations that are outside of the gut, outside of the GI tract. And why is this happening? The body's immune system is attacking not just the inflammation of the intestines of the GI tract, but also the joints. Next slide. So what are the different types of arthritis? So there are many types of arthritis, and the ones that would be in patients with inflammatory bowel disease could be what we say spondyloarthritis, or we call that now axial spondyloarthropathy, psoriatic arthritis, Also, inflammatory bowel disease associated with arthritis, which is what we call a seronegative arthritis, and even rheumatoid arthritis is increased a little bit in patients with Crohn's and colitis. There are other kinds of arthritis that we won't talk about too much, but most of us on this call will get, if we don't already have, osteoarthritis or degenerative arthritis, and that's not increased in Crohn's and colitis, but it's common in most people. Next slide. So in spondyloarthritis, or SPA for spondylo, A for arthritis, there are many areas affected in the body. So first of all, this usually goes with a special genetic test, the HLA-B27 gene, and these patients is often positive. And they can have arthritis in only their spine, like their low back, their spine around their rib cage or thoracic spine, or their neck, their cervical spine, but they can also have involvement in their shoulders, their hips, and also small joint or peripheral joint involvement, such as wrists, fingers, ankles, toes, and even the knees. Psoriatic arthritis might occur in this subset, this umbrella term of SPA. Inflammatory bowel disease associated arthritis is often under this umbrella term as well. Eye inflammation can occur in this type of arthritis, such as what we call acute anterior uveitis. And inflammation can be at sites where there's tendonitis, the tendon inserting on a bone, like at the side of your arm, or the Achilles tendon at your heel. So it can cause inflammatory tendonitis. So not just tendonitis from overuse, but with inflammation, swelling, and warmth. Next slide. So when we look at people suffering with Crohn's and colitis, the arthritis is called inflammatory bowel disease associated arthritis, or we also call it enteropathic arthritis, meaning they have gut involvement, the enteropathic, and they have inflammatory arthritis. So approximately 1 in 5 people with inflammatory bowel disease will get this type of arthritis, or it's quite common. 20% of our patients with Crohn's and colitis could get this kind of arthritis. It's different from rheumatoid. Rheumatoid loves to affect small joints, especially the hands, especially symmetrical. Enteropathic arthritis that goes with Crohn's and ulcerative colitis likes to affect especially large joints in the legs. So the knees, the ankles, the hips. It can also affect the spine. And there's 2 patterns of this kind of arthritis. One is when the inflammatory bowel disease flares, the arthritis flares. The other is the inflammatory arthritis might be doing well, and the arthritis might flare on its own. So it can be concordant, where you get a flare up, say, of your Crohn's and your knee swells, or it could be discordant. Your Crohn's might be good and the arthritis does what it wants to do. So it's about half are concordant, half are discordant. Who does it affect? More common in men or boys than women or girls, so more common in males, and especially in the age group of about age 15 to 45. It can occur earlier in pediatric inflammatory bowel disease, and it can, of course, even start later in people who have later onset Crohn's and colitis. So about half these people who have the enteropathic arthritis will be HLA-B27 positive. And that's where in rheumatology, we see the diseases of the spondyloarthritis, like axial spondyloarthritis. So you're getting an idea that if that gene is positive, they're more likely to have inflammatory arthritis and more likely also to have the spine involved, the low back, the thoracic spine, or the neck part of your spine. Next slide. So again, joint pain is common in people, whether they have inflammatory bowel disease or not. So about 40 or 50% of people living with inflammatory bowel disease will have joint pain. And you know what? That's very similar to the general population. But the enteropathic arthritis, the inflammation from the joints when you have this problem, it's more common in Crohn's than ulcerative colitis. So it's about 1 in 6 to 1 in 5 people with Crohn's, and it's about 1 in 10 people with ulcerative colitis or other colitis. Next slide. So what are the genetics around this condition? So there is an overlap. It's not 100% overlap, but genes associated with inflammatory bowel disease also can be associated with other inflammatory arthritis conditions, such as rheumatoid arthritis. So although the other arthritis I just told you about is more common, 10% of colitis, about 15 to 20% of Crohn's, rheumatoid arthritis is also more common. So in the general population, rheumatoid arthritis is about 1% of people. It's about 3% in Crohn's and colitis. So it's about 2.6 times higher. So it's not a lot higher. It's not as high as the other arthritis, but it's still increased. And this will be important when we talk about the treatment options, because not always will the arthritis treatment options help the colitis and vice versa. Next slide. So, when should someone with inflammatory bowel disease see a rheumatologist? Next slide. It's an excellent question. So often if we see patients with inflammatory arthritis, so if your gastroenterologist sees a big swollen knee and it doesn't settle down quickly, you should be referred. If you have low back stiffness, you're a young person, it's better with activity. It's in the buttocks, usually one side or the other, sometimes both, and it wakes you up in the middle of the night with pain. It's better once you get moving after being stiff in the morning. You should be considered to be referred. Also on these pictures, if you have anything such as a severe ulcer that's called pyoderma gangrenosum, or lumps on the legs that are called erythema nodosum, the rheumatologist can sometimes help with treatment. If you get recurrent or quite symptomatic uveitis, that's inflammation of the part of the eye that causes pain, light sensitivity, so it's hard to see in the bright sunlight and painful, and or decreased vision. If this is recurrent and frequent, we can help on some of the treatments. And if you have frequent sores in your mouth, such as someone with Crohn's disease, we can help there too. So obviously arthritis, but some of these other extra intestinal manifestations we might be able to help with by prescribing drugs, talking about treatment options with your specialist. So the inflammatory back pain usually starts, this is like ankylosing spondylitis, axial spondyloarthropathy. It usually starts younger, more common in men, age 45 or less. It's often a gradual onset and it's chronic. So chronic means it's been around for 3 months or more. You can have a lot of stiffness in the low back in the morning, taking at least a half hour or more to loosen up. Night pain that I mentioned, improving with exercise and not really improving with rest though. It doesn't radiate down the back of your leg. That would be more buttocks pain. Radiating down the back of your leg would be more sciatica. So it's not, it's in the buttocks or the low back. It can be in the rest of the spine, so the neck and the thoracic spine. So another sign that I mentioned is this erythema nodosum. So this is a patient that we injected her knee. So you see the Band-Aid, and she has those little red lumps. They are usually on the legs, rarely on the arms. They can come and go. They're more common in Crohn's than in ulcerative colitis. And about 10%, maybe as high as 15% of people with inflammatory bowel disease will get this erythema nodosum. So they're red, they're raised, you can feel them under the skin like a nodule, and they're often quite painful. And if you have one, you usually have more. So they're often multiple, and they can come and go, and we can help to treat them if need be. So what are some of the common symptoms beyond the joints in enteropathic arthritis? We look for skin psoriasis, dry scaly skin on the scalp, behind the ears, on the elbows, on the outside part of your elbows, on the knees, around the belly button, genital area, the crack of the buttocks as well, and then all over the place beyond that. Aortitis would be inflammation of your aorta, which is in your chest, where blood vessels come off of your large blood vessel. True, but very rare. You can have burning when you pee without having an infection, so that's called non-specific or non-infectious urethritis. You can have the Achilles tendonitis. You can have a sausage digit, a big fat finger or toe. Obviously, the inflammation of joints like a swollen knee or other inflammatory arthritis. Having the acute anterior iritis or anterior uveitis, so pain in your eye, poor vision, and inflammation when the ophthalmologist or optometrist looks with the slit lamp. And also there can be conjunctivitis. So there's lots of different things we're looking for when someone's referred who has inflammatory bowel disease when they come to a rheumatologist. So patients with one or more swollen joints may need to be referred to a rheumatologist, especially if they're going on for a long time. If it's a knee swelling with the Crohn's is treated, the knee swelling is gone, great. If it's a large swelling, we might want to drain it and give a cortisone injection. And if there's recurrent or chronic inflammatory arthritis that isn't well controlled with the inflammatory bowel disease treatment, then you might also get referred. And we do see this. So we don't usually say just joint pain without inflammatory arthritis, because the joint pain might be treated by Tylenol, heat, and other measures. If it's a big swollen joint, we can usually help that more so as a rheumatologist. So there are drugs that you use with your inflammatory bowel disease, and there's also drugs that we consider that might help the inflammatory arthritis spectrum of conditions that I mentioned. So not always do they overlap. So let's look at the drugs. So if you have spondyloarthritis, the drugs that could help are the TNF inhibitors. So in SPA, you might have been offered ever adalimumab. The trade name back when was Humira. Now there's 8 other biosimilar adalimumabs. Infliximab, the trade name is Remicade. And there's about 4 other biosimilar infliximabs. Also golimumab or Simponi. These are approved in inflammatory bowel disease and can be helpful. And we also might use the JAK inhibitors. So tofacitinib works only in or is only approved in ulcerative colitis, but upadacitinib or Rinvoq is approved in ulcerative colitis and in Crohn's. And all those could be helpful for the spondyloarthritis. There's drugs that might help for your inflammatory bowel disease, but don't really have good data in helping at least the spine involvement in spondyloarthritis. These drugs are the IL-12/23 inhibitor, so Stelara or ustekinumab, and now there's one biosimilar for that approved. There's also the IL-23 inhibitors, so risankizumab or Skyrizi, and also gulsokimab or Tremfya. There's vedolizumab, which is Entyvio. There's a couple other classes of drugs, including Zeposia. So on this side of the table, these drugs don't help in the spine involvement of inflammatory arthritis when you have your Crohn's or ulcerative colitis. Also, sometimes you'll be on sulfasalazine or Asacol or other drugs that are like Asacol, the 5' ASA drugs, they don't really work in the spine of inflammation. Azathioprine or methotrexate don't really work in the spine inflammation, but methotrexate can help if there's swelling in a peripheral joint like a knee or an ankle. So the spa-friendly drugs are one side, the not spa-friendly are the other side. And so we work with a gastroenterologist to say, okay, you're on treatment, you've broken through. Do we need to add something? Do we need to increase the dose? Or do we actually need to switch to treat both problems if we can't get around it, treating it locally, like draining a knee and injecting it, or other drugs that way? So if someone has psoriasis or psoriatic arthritis, again, the one column are the ones that could be helpful in patients suffering inflammatory bowel disease. So the TNF inhibitors that I talked about, the JAK inhibitors that I talked about, but also with psoriatic arthritis, the disease-modifying drugs, we call them conventional synthetic disease-modifying anti-rheumatic drugs. So we just call them DMARDs. So methotrexate or sulfasalazine could be helpful, less so azathioprine. But if you're on azathioprine, that's also called Imuran. For your inflammatory bowel disease, we might consider increasing the dose, but it's usually not very good in psoriatic arthritis, but it's not impossible to use it in psoriatic arthritis. Now, there's drugs that really help psoriasis that can also help your inflammatory bowel disease, and they're okay on the joints. They're not as good on the joints as the other ones I've talked about, but drugs, again, like that ustekinumab or Stelara, the risankizumab, the guselkumab, they're very, very helpful on psoriasis, very helpful in many patients on inflammatory bowel disease, and can help the psoriatic arthritis somewhat. Then you have the drugs also that you use, and you're going to see the same list, the vedolizumab, the next two, and we don't use them in inflammatory arthritis. And vedolizumab in general, because it's mostly gut specific, doesn't seem to work very well for the joints. So we've talked about a lot of different things. So enteropathic arthritis and other non-gut symptoms of inflammatory bowel disease are common. At least 10 to 20% of people living with inflammatory gut disease will have enteropathic arthritis. Crohn's disease is linked to more non-gut symptoms than ulcerative colitis. So Crohn's has more of these, what we call extra-intestinal symptoms. Rheumatoid is about 3 times more common in inflammatory bowel disease, especially Crohn's, but it's not as common as the other type we talked about, the enteropathic. Some inflammatory bowel disease drugs don't work well for inflammatory arthritis, and some of your IBD drugs do work really well for inflammatory arthritis. So this is where the rheumatologist, the arthritis specialist, works with your gastroenterologist to come up with the best treatment plan. The TNF inhibitors that are approved in Crohn's and ulcerative colitis, and the JAK inhibitors approved in Crohn's and ulcerative colitis are pretty good options when you have both inflammatory bowel disease and inflammatory arthritis present. But we do work with the other conditions, such as psoriasis and the psoriasis drugs that might really help your Crohn's or ulcerative colitis, and we don't want to stop those drugs if they're going well. And the treatment aims to control all the affected areas. So sometimes someone might be on inflammatory bowel disease treatments, such as, say, vedolizumab, and we might add a TNF inhibitor to help the inflammatory arthritis. So sometimes we combine the drugs because there's different indications for different drugs. And the care could involve multiple specialists. If you have iritis, the ophthalmologist or optometrist, If you have bad psoriasis or pyoderma gangrenosum, maybe the dermatologist, the rheumatologist for some of these other conditions, the inflammatory arthritis, erythema nodosum, pyoderma gangrenosum. So we all kind of work together to try to help out what the symptoms and signs are for each individual patient. So I wanted to keep this short because I wanted a lot of time for questions and answers, because that's where a lot of people seem to get the best benefit.
Perfect. Thank you so much, Janet. We will now move on to the Q&A portion of the evening. So if you have a question, please comment in the Q&A box found in the Zoom menu bar. And we cannot, again, just a note, we cannot answer questions related to specific medical conditions. So I had compiled a few questions that participants had sent in prior to the Zoom to us during their registration, so we could quickly go over those.
Great.
Perfect. So the first question was, I would like to learn how to help my immune system be less active in triggering this disease while keeping it at a healthy level for the rest of my body. Are there any dietary supplements that can help with this?
So that is an excellent question. And the short answer is never short. So eating a healthy diet, so we often say a Mediterranean diet. So it's high in olive oil, fish, especially deep water fish, salads, lentils, chickpeas. That can help inflammation in both inflammatory arthritis and also in inflammatory bowel disease. But it's not the whole answer. It's just part of the answer, because if you need your treatments, you'll still have to use them. Maintaining a good health where you're eating a variety, especially things that aren't setting off your inflammatory bowel disease. So if I tell someone to have a lot of fiber, sometimes that helps, sometimes it doesn't in a healthy diet, depending on how your body reacts with your inflammatory bowel disease. We usually want to make sure you're sufficient in vitamin D. Vitamin D can be anti-inflammatory to a small degree, and it's healthy for your bones. It's good for your immune system. And by vitamin D, something like 1,000 units a day. If you have osteoporosis, thin bones, then maybe you might or might not be recommended to be on more. Getting adequate omega-3s. So omega-3s could be taken as a supplement. We always say where possible, it's better to get it in your diet. So foods rich in omega-3 would be fish, especially deep water fish, sometimes nuts, and there's a whole bunch of other areas that could be rich in omega-3. So omega-3, vitamin D, Mediterranean diet, all those can help your immune system. And beyond your diet, a few things that I can say is regular exercise, getting a good sleep, meditation, being kind to yourself, having a good routine for sleep hygiene, positive journaling each day might help you, just because that can help in a way lower the stressors on your body, help your immune system a little bit. All these, again, are in addition to the regular medications that you would be prescribed. It's an excellent question, and I wish I had more specific foods to eat that might be helpful. But at this point in time, that would be the most proven data of what I've told you about.
Thank you so much, Janet. That was really comprehensive. I'll go on to the next question, which is, when discussing diagnostics, could you also clarify where these tests can be obtained and whether they are covered by the provincial health insurance?
Right. So in general, the diagnostics, I think there's two ways we look at it: getting your inflammatory bowel disease diagnosed, and then getting your inflammatory arthritis condition diagnosed. So for inflammatory bowel disease, as everyone who's been diagnosed knows, it's a journey. Easy tests are done looking for low blood or anemia. Scopes are done, upper and lower endoscopy. A poop sample, so fecal calprotectin is done, and fecal calprotectin is not covered on every provincial health insurance. I think there's a lot of advocacy going on to get it covered. It's not specific for inflammatory bowel disease, so anything that can break apart the mucosal lining, like an ulcer or the non-steroidal anti-inflammatories that can cause erosions in the stomach or the gut, could make it abnormal. But fecal calprotectin is covered in some private insurance, and sometimes it's covered by patient support programs if you're on an advanced therapy such as a biological or a JAK inhibitor or something. Then when we're looking at the diagnostics for inflammatory arthritis, there shouldn't be the same test done on everyone. Not everyone would need an X-ray. Some people need an X-ray of their low back, the joints that hook your low back spine onto your pelvis, so the sacroiliac joints. And often if that's normal and we're suspecting axial SPA or ankylosing spondylitis type condition, we might have to move on to an MRI. It's a very special one, a T1, T2 stir image, so we know how to order it. And everything I've just talked about on the diagnostics of arthritis are reimbursed by the healthcare systems. If we're suspecting rheumatoid arthritis, that's only 3% of people with inflammatory bowel disease. All provinces now finally cover the anti-CCP antibody. The rheumatoid factor has been covered, like reimbursed for years. So in general, fecal calprotectin or very special tests that we might be doing might not be covered fully on every healthcare system in Canada. But in general, almost all the things, your scopes, your advanced imaging, such as CT scans of abdomen, MRIs, etc., would all be covered by the health insurance, fortunately. When we talk about drugs, not everything is covered on the provincial health insurance, and they vary by province. And that question might or might not come up. But in general, if you need a certain medication that's proven in inflammatory bowel disease, your gastroenterologist will work very hard along with patient support programs to get it covered for you, to get it reimbursed.
Perfect. Thank you so much, Janet. The next question is, if I'm already taking Remicade, could it mask the symptoms of arthritis?
So again, another excellent question. So Remicade is infliximab, and now there's all the other names, Inflectra, there's a whole bunch of names, Renflexis, etc. So Remicade and infliximab, there's several biosimilars of it. So if it masks the symptoms of arthritis, we're happy. It's actually treating it then. So we use infliximab kind of drugs as well to treat inflammatory arthritis. We don't use it as much as the gastroenterologist for a couple reasons. We can't always push the dose high enough. We don't usually follow drug levels or look for anti-drug antibodies, whereas the gastroenterologists do. We don't always get reimbursement at the highest doses where it's reimbursed for your inflammatory bowel disease. So we don't use it as much, and the retention in rheumatology isn't as good as the retention on this drug over years for individual patients in gastroenterology. But if it masks the symptoms of arthritis, that's okay. That means we're treating it because it actually treats arthritis. So it's not, you're not ending up with the inflammation and then masking the symptoms and getting arthritis damage. If it treats your symptoms, it should be helping to reduce the chance of getting damage in your joints.
Perfect. Thank you. The next question is, what are effective ways to manage arthritis pain for people with ulcerative colitis or Crohn's disease?
So I'm going to talk in a few different categories of managing arthritis pain. So if your inflammatory bowel disease, your Crohn's or colitis is active, so a lot of inflammation going on in your GI tract and your gut, then your gastroenterologist will not want you to take high doses or maybe not any doses of the non-steroidal anti-inflammatory drugs. That's your Advil, which is ibuprofen, or also called Motrin, Aleve, but also Celebrex, which is celecoxib, naproxen, which is naproxen, meloxicam. There's a whole bunch of NSAIDs. If you have arthritis, say you have degenerative arthritis, or what we call osteoarthritis in your knee, we do use topical therapies. So if it's 1 or 2 joints, topical Voltaren gel or diclofenac gel can be helpful. Injecting a joint can be helpful. So if it's 2 or 3 joints that are quite inflamed and painful, we can inject with cortisone and freezing and cool down the inflammation and help the pain. So these are effective ways. Then also looking at those, what we call those advanced therapies. So some of you might be on methotrexate isn't used much for inflammatory bowel disease, but you might be on it for various reasons. We can increase the dose or add to it if it's not fully controlling, if you have arthritis pain as well. Azathioprine, Imuran, doesn't help most inflammatory arthritis very much, but say if you have lupus and Crohn's, or lupus and colitis, we can use azathioprine and push the dose if it's tolerated and if we need to. So those are the conventional synthetic drugs. If you're on 5' ASA, so it used to be called Asacol, there's a few on the market. It doesn't treat arthritis pain as well as switching you over to sulfasalazine. So sulfasalazine is 5' ASA, one of them, with a sulfa molecule. 5' ASA is two of these, Asacol, I mean, is 2 5' ASA, but no sulfa. So if you're not allergic to sulfa, we can switch you over to sulfasalazine to treat your inflammatory bowel disease as well as your inflammatory arthritis. Then, so that's the conventional synthetic disease modifying drugs. Then if we move to the biologicals and the advanced therapies, so the JAK inhibitors, which are the, we call them targeted synthetic oral molecules to help you, they could treat the problems that we mentioned as well as your inflammatory bowel disease. The biologics, such as the TNF inhibitors, that infliximab, adalimumab, maybe sertolizumab pegol, which isn't approved in Canada, but is approved in the US for inflammatory bowel disease, and golimumab, which is also called Symphony. That could help potentially the inflammatory arthritis and the inflammatory bowel disease. If you're on vedolizumab or some of the other ones I talked about that don't really help as much in some of the inflammatory arthritis, then we try to work on treating with adding another drug on the rheumatology side if we need to. And then finally looking at the drugs, the IL-12/23, that's ustekinumab or Stelara, and now there's a biosimilar, or your Skyrizi, which is risankizumab, or your gulsulkamab, which is Tremfya. They work in psoriatic arthritis. They work really well in psoriasis. They might be working very well for your inflammatory bowel disease if you're on it, but they don't work in the spinal involvement. They probably don't work well of the spinal involvement of Crohn's or ulcerative colitis. So then we have to kind of look at what are we going to do to add or change up the drugs. So I'm being a little bit repetitive from what was in the talk, but I think being repetitive, number one, helps you remember, but number two, it gives you some hope to go, okay, there's a way that we can work with together, the two specialists, to help the various problems that you're experiencing.
Thank you, Janet. I will go to the next question. How can a doctor determine if joint pain is related to Crohn's disease rather than being due to age?
Well, sometimes it's not easy. So as a for instance, many women more than men will get arthritis at the middle knuckles of their fingers and at the end knuckles of their fingers and at the base of the thumb. And that would be what we call erosive osteoarthritis. It can still look very inflammatory, swelling, pain, eventually bony change. And that would be something that the drugs for your Crohn's or your colitis won't work, but the drugs that I use to treat conditions like rheumatoid arthritis or psoriatic arthritis also won't work. So sometimes that's mistaken, say, for rheumatoid arthritis or psoriatic arthritis. So if it looks like there's inflammation and swelling, and if your family physician or nurse practitioner or your gastroenterologist doesn't have a good idea of what it is, sometimes other tests will be done, such as blood tests or an x-ray to say, is this inflammatory or mechanical, like degenerative arthritis problems? And sometimes patients with these sorts of symptoms will be referred to a rheumatologist. Then if it's a big swollen knee and you're 32 years old and you haven't had trauma, and it doesn't feel like you've had a meniscal tear and you have Crohn's or colitis, then we would wonder, certainly in that person, is this an inflammatory arthritis? That's enteropathic. That's associated with your inflammatory joint, inflammatory bowel disease. So sometimes it's pretty easy and sometimes it's tricky. And that's where sometimes I'll get a referral. It's better to ask a question and get an answer than to not know. So having a referral and we say, oh, this actually isn't inflammatory arthritis, nothing wrong with that. We can still give ideas of how to treat joint pain that are related to mechanical or degenerative arthritis, or as you get older, almost all of us will get some degree of osteoarthritis. So that's okay if you can't tell the difference, because then if you're sent to a specialist, they can help out, like a rheumatologist.
Thank you. The next question is, will having an ostomy affect the type of work? Oh, sorry. This is from a previous slide. Apologies.
Yes, yeah.
That's from the previous one. Okay, so the
Yeah.
next question is, what is migratory arthritis and is it common in Crohn's patients?
Right. So sometimes it is common to have arthritis that comes, the inflammation comes and it lasts a while and then it goes. So migratory is coming and going. And so many people with Crohn's or ulcerative colitis, inflammatory arthritis, will have a big swollen knee, and maybe after days or weeks, it's gone, then a big swollen wrist, then over to the other knee, so migrating around. And yes, that can be common, and it is, again, almost everything we've said is more common in Crohn's than in ulcerative colitis. And we can treat that by trying to decrease how often the flares are coming. And it might be medicine that you use for your Crohn's, or we might add in other treatment depending on whether we think we can modify the Crohn's disease treatment to increase it or add, or what do we have to do to help this from coming so often. And it can be quite painful and it's unpredictable.
Thank you. So these are all the questions that we had collated from the Zoom during the Zoom registration, but there are also some questions in the Q&A box that maybe, Janet, we can go through quickly.
Yes, yeah, that'd be
Perfect.
great.
Okay, so the first question is, are there no links between IBD and osteoarthritis? My osteoarthritis seems to improve with IBD drug management.
That is very interesting. So first of all, I didn't talk about it, but the gut microbiome is abnormal in many people, even before they get sick with their inflammatory bowel disease, but also in rheumatoid, in axial spondylitis, in psoriatic arthritis, in gout, and in osteoarthritis. So I wonder, as just trying to think it through, this is a guess, I don't know if it's true what I'm about to say, but if you get your inflammatory bowel disease treatment, and so the bowels are under control, that might improve the gut microbiome, which might help a lot of other things down, like other conditions that are associated with the gut microbiome. I almost don't know of a condition that hasn't had a report that there's an abnormal gut microbiome of all sorts of chronic health conditions. So that's very interesting. That's the first wondering that I have. Another thought that I would have would be, maybe it's not osteoarthritis and maybe it's enteropathic arthritis, so inflammatory arthritis associated with your inflammatory bowel disease. But usually we look at the patterns of your arthritis and can say, oh, no, for sure that's osteoarthritis by the history, the physical, the pattern of the arthritis, or oh my goodness, I think this is enteropathic arthritis or psoriatic arthritis. So it's a great question. And when you see your specialist next, your gastroenterologist, you can ask the question, is this really osteoarthritis? And here's my association that I see, and see what they say.
Thank you. The next question is, do any of the IBD drugs trigger arthritis symptoms?
Right. So in general, they shouldn't trigger arthritis symptoms. So vedolizumab has it's mostly gut specific, but it does have a report by Dr. Brian Fagan, who has done many studies in inflammatory bowel disease that actually suggests it might actually help arthritis, but we don't think clinically it does, but it probably helps arthritis for the people who are concordant, say their Crohn's flares and their joint flares. So if it treats the Crohn's effectively, the joint should get better. So that's the opposite of triggering, that's helping, even though it's a gut specific drug, not so much systemic absorption, it's gut specific. On the other hand, we don't usually see that inflammatory arthritis is triggered by the drugs, but as a for instance, we have patients well described, including in IBD, that they're on infliximab or adalimumab, and they get paradoxical psoriasis. And these drugs treat psoriasis. They're not as good as the newer treatments for psoriasis, but they could cause psoriasis. So that's a flare of a skin thing where it should be treating that. And we think it's an imbalance of the inflammation of, this is kind of getting, I'm going to make it simple, but the inflammation of interferon and TNF, when one goes better, the other goes, one goes low, the other goes high, and that imbalance might trigger psoriasis. Does it trigger inflammatory arthritis though, the treatments? Not usually. Anything can happen, but not usually. And we would say probably unrelated to the treatment. If you're on good treatment for your inflammatory bowel disease, and then say you get a big swollen ankle, we'd say we don't think your inflammatory bowel disease treatment caused it.
Thank you. The next question is, I know you talked about the co-occurrence of arthritis and IBD, but this question is, someone's asking, is there anything you can do to help prevent arthritis? I'm assuming, given
Yeah,
that they may have IBD too.
right. So I'll answer it in the way of IBD, and then I might answer it more broadly.
Sure.
So this isn't proven, but there's thinking that if we can get inflammatory bowel disease treated early and highly put people into remission, so deep remission, treat it early, that we can potentially, which makes sense, prevent the bowel complications of inflammatory bowel disease, adhesions, need for surgery, etc. But there's a thought that maybe also it could dampen the chance of the extra gastrointestinal manifestations. So the manifestations beyond the gut. That at this point in time is kind of speculation, because we probably need 10 years of highly effective treatment on IBD with good studies looking at people who didn't get treated as effectively or didn't get into remission versus those that did, and see if inflammatory bowel disease associated other problems like pyoderma gangrenosum, erythema nodosum, inflammatory arthritis, to see if they go down. I truly believe, but it's a belief, we don't have all the data yet, that if your inflammatory bowel disease is treated effectively, especially early, that you'll get less arthritis. But just because I believe it, we haven't proven it yet, but it just makes a lot of sense. If we talk about preventing arthritis, just like someone asked about the healthy sort of anti-inflammatory diet that could be helpful in inflammatory bowel disease, the same things, adequate vitamin D, Mediterranean diet, having a diet or supplements rich in omega-3 fatty acids, all those things can help decrease the chance of what I'll call inflammatory arthritis, whether it's associated with inflammatory bowel disease or just for regular healthy living people. A few other things that are shown surprisingly to improve like to reduce the chance of getting, now I'm going to talk about rheumatoid. So healthy diet, regular exercise, stress management, little or no alcohol, all those lifestyle changes, and a diet or supplements giving vitamin D or omega-3, all those features can reduce the chance of getting rheumatoid arthritis, and it can reduce it by about a 1/3. So lifestyle matters in what we do for getting chronic disease, and all the stuff you've been told already about eating healthy, exercising, managing stress, all easier said than done. And I understand that. Not having much alcohol, little or no alcohol, etc. All those things can reduce some chronic diseases to some degree. Sometimes you don't do anything wrong. You have a perfect lifestyle and you still can get autoimmune disease, or you can still get sick. So nothing's ever 100%.
Perfect. Another question we have is, I think this was a clarification during the presentation.
Yeah.
So someone was asking to clarify, the pain in the SI, I'm assuming small intestine, or the bum area is likely enteropathic arthritis or RA. I guess they're asking when you mentioned.
Oh, right. So the low back pain, so the SI we're talking about here is the
Oh,
sacroiliac.
yes, yes,
So
sorry.
if you put your hands on your hips, which aren't your hips, that's your pelvis, because everyone puts their hands on their pelvis when we say it. Where your thumbs are at the back of you, that's the start of your SI joints in general. So when you put your hands on the top of your pelvis, or when we say put your hands on your hips. And so the SI joints are the enteropathic or the ankylosing spondylitis type, and rheumatoid arthritis does not involve the low spine.
Perfect. Thank you. Um, can a patient have random joint pain associated with IBD when no rheumatoid arthritis has been found?
Yes, but random joint pain, remember I said 40 to 50% of people, just regular people, will have joint pain. And in inflammatory bowel disease, 40 to 50% will have joint pain. So, you injure your elbow, you didn't do anything, your shoulder's sore, then it gets better. Your hands are sore and then they get better. You might have some overuse tendonitis. You go for a long walk and you get plantar fasciitis. All those things are common in the general population. But yes, there can be joint pain, like someone asked about migratory, that comes and goes, that could be a prelude to rheumatoid arthritis. So we have something called palindromic rheumatism, just like that migratory. A palindrome is coming, going at a certain frequency. And palindromic rheumatism is having a joint, usually one at a time, swell. It peaks by 1 day, fully resolved by 3 days, only to be gone and come again somewhere else. Peaks by 1 day, fully resolved by 1 to 3 days. That's called palindromic rheumatism. And 1/3 of people with that kind of inflammation singly in a joint, coming and going in various joints, 1/3 of them will develop rheumatoid over time. 1/3 will stay about the same, and 1/3 will get better over time. So it's a very good question, because there's lots of different things that might be the answer to this question.
Thank you. We're almost at 8. Maybe I'll ask you 2 more questions and then we can.
Okay, I'll try to be appropriate and fast.
Okay, sure. Um, One question is trigger finger also related to erosive osteoarthritis?
So trigger finger is a different thing. So that's the fancy name is the trigger's locking like this, and we have to open it. It's called stenosing tendonitis. So it's a trigger finger is the little canal has a thickening on it, so the tendon gets stuck. Your finger locks and you have to open it. So it's related to anything and nothing. So in other words, it's related to overuse, someone working in a factory. It's more common in people with diabetes, with thyroid disease. It's more common in people with inflammatory arthritis, but it's not more common in osteoarthritis. Great question.
Okay, awesome. Um, Okay, let's see. Is there a treat? So someone has asked, there's actually a lot of questions, but I think some of the questions, Dr. Pope, if you're okay, I can actually send them to you and I
Yes,
can try
yeah.
to see. So I'll try to check another one. Um, Let me see. I saw a question about, are there any treatments for oral ulcers?
It depends. If it's from active Crohn's disease, then they might increase the Crohn's treatment. You can get a prescription where appropriate. You'd ask your healthcare provider for what's called Oracort. It's topical steroid and it's like toothpaste that sticks on there and that can help. Magic mouthwash if it's really bad. Your drugs rarely can give oral ulcers. Azathioprine, methotrexate, those sorts of drugs, not so much the advanced therapies. And also you could have had antibiotics if you had an infection, or even without that, and get thrush that can give ulcers as well. And then we would treat thrushes of yeast in the yeast infection in the mouth.
Okay, thank you. Did Dr. Pope clarify if the biosimilars of TNF inhibitors that are SPA friendly were also
Right. So the biosimilars are the very same as the first name brand product, or what we call the originator. So
Mhm.
if Remicade works, then infliximab of any other name works to help the thing. So that's a really good question. Sorry if it was confusing.
Perfect? Um, so I actually, just a reminder, I guess we go until 8:30. So are you okay actually going a little bit more or?
Yes, absolutely.
Oh, okay, perfect. So I think there's just five more questions, so we might as well get through them. What of tendon pain as opposed to joint pain and arthritis? Does treatment vary for one over the other? I guess they're asking for the difference between tendon pain, joint pain, and arthritis, and if the treatment
Right,
varies.
right. So, I mean, any joint we have has muscles that insert with tendons around to make a joint move. So tendinitis is common in the general population, but a more inflammatory tendinitis we call tenosynovitis, and it's far more common if someone has ankylosing spondylitis. A big swollen Achilles tendon at the back of your ankle, your heel, that's Achilles tendonitis. So we use tendonitis. It sounds like itis, sounds like inflammation, but most tendonitis is not inflammatory. But in our inflammatory conditions, far less in rheumatoid arthritis, far more in psoriatic arthritis or the axial spondylitis, they get more tendonitis.
Okay. The next question is, how common is arthritis without any swelling?
So, you could have arthritis and today you're not you're not having the joint be active. But if you've never had swelling in a joint, and swelling could be where it feels mushy and swollen, like fluid inside, quite warm, and might be pink or red or not discolored at all. That would sound to us like an inflammatory arthritis, unless if it was an injury or something. Whereas if you have osteoarthritis, you might just have creaking of your knee when we move it, where it doesn't ride smoothly, and bony change without having any swelling at all. So if it's inflammatory arthritis, there should be swelling, but we also can't see swelling in the spine. So that would be only on imaging where we'd see increased inflammation, fancy imaging on the spine like an MRI.
Tom asks, there has been no mention of hydroxychloroquine in treating RA and IBD. With apologies of not knowing medical terminology, how do you feel about the combination of Plaquenil and IBD medicine? It's a very specific
Right.
question.
So we use hydroxychloroquine, Plaquenil, all the time in lupus and in rheumatoid arthritis, hardly ever in the seronegative arthritis conditions. But if you have a condition that needs hydroxychloroquine, Plaquenil, there's no problem using it with your IBD meds, but it doesn't help IBD. It's not IBD friendly. It's not unfriendly. It just doesn't do anything to help your Crohn's or colitis.
Does Crohn's related inflammatory arthritis affect the ligaments? If so, what's the treatment when you are already on the combo of Humira and Imurin if ligament pain not well managed?
Right. So the ligaments, that would be tendons or tendon insertion. But the first thing I would ask, or not asking the person, don't worry, but in general, if I'm seeing a patient, the
Sure.
first thing I would ask is this widespread tendon insertion pain, like a chronic pain condition? Fibromyalgia is really common when you have bad gut pain from your inflammation, you don't of your Crohn's, or ulcerative colitis. You don't sleep well. And also fibromyalgia is a few percent of the population anyway. But so if you have widespread pain at all sorts of insertions, I'd wonder if this isn't inflammatory, but is fibromyalgia, which is widespread pain, arms, legs, back, neck, lasting 3 months or more, and not for any other reason. And so I would wonder about that. I'd wonder about, is there strain from a hobby or a job that's causing problems? You know, someone on a factory line might have a lot of ligament pain from overuse if they're doing something all the time. And then if it is thought to be inflammatory, we might need to go further and say, do we need imaging, like an ultrasound, to see if it's inflammatory or mechanical, or a torn, you're not going to have a bunch of torn ligaments, but a torn tendon or something like that. And then we would kind of determine, would a topical Voltaren gel or diclofenac gel be helpful? So I think we got to get the right diagnosis that will then lead to the treatment. So it's a really good question. And it is sometimes difficult to know, is it the inflammatory bowel disease associated, or is it for a fully different reason? And we can usually sort that out.
Okay, perfect. Um, oh, sorry, just to clarify one of our previous questions, they were wondering who would take care of IBD oral ulcers. Is it a family doctor, a gastroenterologist, or a rheumatologist?
The answer is yep, any of the above. So
Okay.
probably if it's in between gastroenterology appointments, it'd be the family doc. If the family doc thought it wasn't like from yeast, needing antifungals, nystatin, fluconazole, etc., then they might say, oh, this could be your Crohn's. It won't be from ulcerative colitis, or this could be from your meds that you're on. So see your gastroenterologist. And rheumatologists sometimes get involved because we're co-managing the patients, and we have to all be aware that methotrexate, azathioprine, sulfasalazine can all cause oral ulcers. Not for everyone, not for most people, but for some people.
Okay, and we're finally at our last question. And I'd also remind everyone that there's still a poll, so if we could just hang on a little
Yes.
bit
Hang
more.
tight.
Yes. So last question. I learned that vitamin D3 gets calcium into your bloodstream and vitamin K2 takes it into your bones, in turn strengthening them and improving joint pain. This makes it seem that vitamin D3 may not be effective on its own. How much K2 per 1,000 units of D3 are required? Again, if it's too specific, please.
No, it's a great question,
Yeah.
because we get these questions all the time, and I get them two ways. I get them, if someone's on vitamin D, do they need potassium? Or if they're on vitamin D, do they need magnesium? And honestly, I don't know where this comes up. I think at a biochemistry level in some lab somewhere, it might be important, but it's actually not important for you as a human to take potassium or magnesium with your vitamin D. And sorry, it's not just potassium, vitamin K as well.
Yeah.
So we don't think it's needed. And I know that maybe for every 2,000 papers that say it's not needed, one paper might say maybe it's helpful. But in general, the recommendation is get adequate vitamin D in your diet. And in Canada, because we have winter, it's often you don't have enough vitamin D. So consider taking about 1,000 units a day. If you're quite young, like a kid with ulcerative colitis or Crohn's, maybe 400 to 1,000 units. For an adult, 1,000 to 2,000 units, unless if you're low or have malabsorption, it might be far higher, but then your vitamin D level would be checked. And taking adequate calcium by diet first, if possible, 2 servings of milk or milk products a day. That's yogurt, cottage cheese, etc., or foods very high in calcium, like salmon, but nobody eats salmon twice a day. No one could afford it or want it twice a day. And then, so getting adequate calcium, about 500 milligrams per one serving, so 1,000 milligrams a day if you don't take any milk products. And not everyone's bowels can tolerate milk products when you have your inflammatory bowel disease. Some of you with your diarrhea have gone lactose intolerant if you weren't already. So a gram of a gram or 1,000 milligrams of calcium and 1,000 units at least of vitamin D. So you don't really need the K2 or the magnesium. And the final thought on magnesium is enough magnesium for people, if you take it, will give you diarrhea, which is the last thing you want when you have inflammatory bowel disease.
Okay. Ooh, perfect. Thank you.
Oh, and
So,
you want this last question because there's time?
oh, sure. Let's see. What exactly is swollen when you have sausage toes? Joints, tendon, or something else?
Right, that is an excellent question. So a sausage digit, a toe or a finger, is the whole thing is fat. So it's like somebody just put a little air pump and blew up the finger. So the tendon sheath on the inside, the palm or the flexor side, and on the outside, the dorsum or the extensor side, both these are swollen, especially the inside tendon sheath. So that means your finger can't bend, it's quite swollen. But almost everyone with dactylitis will have some degree of inflammation as well in the middle joint. So the middle joint of the toe or the finger, and also the bottom joint, and sometimes the top joint as well. So it's a great question because the flexor tendon sheath, some of the extensor tendon sheath, and often the little joints of the toes or of the finger and the finger or the toe involved are swollen as well.
Perfect. I want to thank you, Dr. Janet, specifically for answering all our questions and taking all that time. And also thanks for everyone for being here. I will quickly launch the post-webinar poll, which should be active now.
And we hope people have enjoyed it and have learned
Yes.
something that might or might not be relevant to them or to their loved ones. And I tried to vote and I couldn't, so I couldn't give myself that I had lots of knowledge now.
You would skew our results, so
I would, that's right.
so I'll just wait a little bit more. I'll wait for another 30 seconds. And
Good. And while you're waiting, someone wants to know if the session has a recording that people could hear it later.
yes, so the session has been recorded both in English and French, and we'll do some edits from our side before we post it online so everyone can have access to it for sure. Okay. Almost at a minute. I will end the poll. So I'd like to, again, thank you to everyone for being here. We really appreciate everyone's participation. If you're interested, please follow us on any of these platforms, and you can hear more about us. So, and that concludes our seminar for today. Again, Dr. Janet, thank you so much for helping us and sharing your knowledge with us today.
Great, thank you. And I think this is really professional. I'm very impressed. I've been on many webinars, so English and French simultaneously. Wonderful audience, wonderful questions. So merci, thank you. I feel privileged to have been here.
Thank you so much. Have a wonderful night, everyone. Take care.